Good evening. My name is Gary Frishman. I'm a reproductive endocrinologist. It's a fancy term for a doctor who specializes in infertility. I came to Providence in 1991 following my wife, and I'm here forever. So I've been here for a long time. I take care of couples with infertility, women with infertility, as well as a range of reproductive problems. What I'd like to do tonight is just very briefly talk about infertility, and then we have a lot of questions, and we'll just start trying to go through all of the questions that we can. And if not, the team will allow ways to try to follow up. I see patients in Providence. Our office is on the east side, next to the Whole Foods across from East Side Marketplace. So we define infertility as the inability to become pregnant, and that affects about 15% of the country. It's one of those things you don't think anyone has until you ask around and you realize how common it is. For better or for worse, there's very much an age-related aspect to infertility, such that a woman who is, let's say, under 35, we ask them to wait a year, and for women that are over 35 or so, 6 months. Having said that, if there's an obvious cause for infertility, meaning we know that there's a low sperm count, we know that the tubes are blocked, we know that there's no periods, we don't obviously make someone wait, and we would do an evaluation at that time. That evaluation can be done by your doctor if they and you are comfortable, or we can do everything. And the evaluation looks at both male and female aspects of infertility. And then we typically address the findings. And then very commonly, we then move quickly to fertility drugs. When I think back 20 years ago, we used to try to narrow everything down, and we would go down these paths to try to find out the last little possible reason. But because our treatments treat pretty much all of those little reasons, and because everyone who sits across from me wants to get pregnant soon, we typically, if there's not some targeted area, would move to fertility drugs, typically an oral medication, often combined with intrauterine insemination, artificial insemination. Sometimes we go straight to in vitro, which is the big gun. That might be if there's a really low sperm count. That might be if we know the tubes are blocked. But typically we try to hold that in reserve for a younger woman until they've exhausted their fertility drugs. I think one of the things that's not appreciated, I think most women know that age is an issue, but the duration of infertility, how long you've been trying, is an important issue. So if someone sits in front of me and says, let's say 30 years old, I'm going to go off the birth control pill next month, what's my chance of getting pregnant any 1 month? I would say about 20%. If that same, another 30-year-old who comes in and they say, I've been trying for 3 years with no obvious cause, what's my chance any 1 month? I have to tell them it's 2%, so low. And those numbers are important because none of them are zero. People get pregnant during the workup while waiting for treatment, but they're all kind of disappointingly low. And therefore, it's what we're trying to build up from. And perhaps most importantly, I want to emphasize that with all of this, I know the incredible stress associated with infertility. And I think it's something our society is not very good at helping with. I think that people can, if you are not pregnant, you are a failure, which is terrible. Your body is failing, you're failing your partner. And I'm fortunate to have lots of resources to help with that. So what I'm going to do is start opening up for questions. And the important disclaimer is that I can't answer specific questions about your care. It's kind of like you take a car to a mechanic and you say, there's just a little bit, I'll tell you what's wrong, but you're going to tell me what to do without actually looking at the car, without actually knowing your history. I can't give you an accurate answer. And what I like to say is, rather than give bad info, I like to give no info, but try to point in the right direction. So how long does it typically take to start the IVF process once the testing and paperwork has been completed? So the first point with that is the in vitro we typically hold until it's necessary, but once the decision is made, we have a fabulous team. One of the big things is to get the insurance clearance, and between COVID and the insurance companies taking time, it used to be they turn it around right away, and now they often say we take 10 business days or 14 business days to get back. So, but I'd like to think it's within a month, but it's multifactorial. But we typically would make a plan and get everything ready. So poor quality embryos, 30 years old, how do you improve embryo quality? And so their physician has suggested that a different protocol would work. And I think in medicine in general, if there was one perfect medicine, like this is the medication that's going to help with your headache, whether it's, it would be the only one on the market, and there's Tylenol, there's Aleve, there's Motrin, different things work for different people. And likewise, with fertility medication and protocols, we have different protocols. And just like what you pick for your headache, not trying to minimize what you're going through, we pick a protocol based on our experience and your personal history. And then we learn from your response. Hopefully we learn that you're pregnant. But if you're not, we learn from your response how you've done. And then they speak to the lab. We look at the number of eggs. We look at the fertilization. We look at the embryos. And that can help drive it. It's very individual. And, sometimes I start with protocol A and move to protocol B. Sometimes I might start with protocol B and move to protocol A. So that those questions, it's a great question, but it's one to ask for your physician. A patient has a question on the biologic clock tests. And let me just talk briefly about what those tests are. So we typically get blood tests and an ultrasound. And again, it may vary based on what your insurance mandates and what, your history. The blood tests and the ultrasound are almost always done in the beginning of the cycle day 2 or 3. And we say the first day of flow is the first day of the cycle. And the key blood test is AMH, anti-Müllerian hormone. And that hormone you can think of as produced by the ovaries, so more is better. And then FSH, follicle stimulating hormone, is the hormone that the brain sends to the ovaries to tell them to make eggs. And I kind of think of the ovaries as the engine to your car, and the brain is stepping on the gas pedal. So if you have to step on the gas pedal harder, if your FSH is higher, that suggests that your biologic clock is further along. And the other test, which is the ultrasound, we call that the antral follicle count. I think of the egg production. I have lots of analogies, I apologize. The egg production as a pipe, and the eggs are coming out, it went under the pipe. And if we want to see what's going to be coming out down the road, we look at the beginning of the pipe. And so that looks at the early small follicles, or what we call the eggs. And similar to the AMH, it's made by the ovaries. So the higher the AMH, the better. The higher the antral follicle count, the better. And the opposite is true with the FSH. The higher the FSH, that's more concerning. And we know there's a wide range of variation, and we know it's a snapshot of time, and that's important. Again, silly analogy, you're driving your car for 5 miles and you check your gas mileage. You can rely on it to a certain extent, but how reliable is it? But having said that, if it is quite off, then you don't need to drive any further to know that. So we tend not to repeat the biologic clock tests because of their relative level of accuracy. So, but the specific question was the low antral follicle count, so not a lot of eggs, and a low AMH, the anti-Müllerian hormone, suggesting the ovaries not producing a lot. So that is concerning, and it's concerning almost independent of one's age. And the answer is even if a woman is young, that's something that I would typically move to earlier rather than later, moving to IVF. And I would choose a much more aggressive protocol. So we said that we have a bunch of protocols that we choose from, and we choose one based on our experience, but based on your individual history. We individualize our care. We treat you as a person, not just the statistic. And in this case, going back to that car analogy, I've never driven your car before, but I've driven a lot of cars. and I'm concerned about the engine, so I would floor it. I would really aggressively step on the gas pedal. I would give you an aggressive protocol to see how your engine responds, how your ovaries respond, understanding that we can't know until we go through. And we know that there's a lot of variability in that. So the short answer is that I would be much more aggressive earlier rather than later. Donor eggs is always an option, but it's never the thing we typically go to first. But if someone's not able to make eggs, then donor eggs is an amazing option. Could a 40-year-old start with IVF when they pay out of pocket? If someone is not using insurance, you have a lot more latitude. The insurance companies dictate. But having said that, women who are over 38, I would consider it standard of care, meaning it's acceptable practice to go straight to IVF because of the decline in pregnancy rates with a woman as she gets older. And furthermore, many women present and they're thinking they might like more than one child. And if you take kind of the slower but less expensive route up front, by the time you come back for your second child, you're older. So it is within acceptable practice and good practice to offer and discuss IVF in someone who's even just 38, depending on their history. And then again, sometimes even earlier than that. So the question is that we've had a baby from IVF, but no more embryos. How long to wait? Two different questions there. There's something called the inter-pregnancy interval. And what that says is that you want to wait between pregnancies to let your body recover. And it's well accepted that if you don't wait long enough, especially if you've had a cesarean, that your next pregnancy is a higher risk. But having said that, depending on what's going on, you can even start the IVF process because you won't be getting pregnant for a while. And then also you may just be freezing your embryos. We do like you to stop breastfeeding before you start that process. We have a question about PCOS, polycystic ovarian syndrome, a very common condition of women with infertility. The single biggest cause is irregular cycles, and within that, PCOS is big. And what they said is that they're going straight to an oral medication called letrozole. The two big medications that we use for fertility are letrozole and clomiphene clomid. Those are the oral ones. And she is trying letrozole. And they said they didn't do any evaluation. So typically, but not always, we do some blood work for causes of irregular cycles, and sometimes rule out other things like thyroid conditions. It's okay not to do an X-ray to check your tubes. It's okay not to check a semen analysis in the absence of risk factors. You know, if you said I had pelvic infection when I was young, I'd want to check your tubes. But as long as you understand that we may be missing something, it's reasonable to take an oral medication, inexpensive, safe, pretty reliable, and try that for a few cycles. And then if you're not pregnant, then we could do the evaluation. Alternatively, if people say, hey, I want to do the full evaluation, I have no problem with that. But the important thing is that you're going to want the regular cycles on these medications. If you take it, don't get a period, bring on a period, take it again, that's not good. So one question is about medical issues, specifically high blood pressure and the medications associated with that. What I do really well, I do. If I don't do it really well, I don't do it. And I did it at OBGYN residency, not medicine. So these are the key things to ask your doctor. Having said that, we have fabulous physicians that specialize in women's healthcare, specifically women trying to get pregnant. And I turn to my colleagues when I have these medical questions, assuming that my patient's physician is not the right person. And so ask your physician, and if they're not comfortable and you're seeing someone like me, we have wonderful chances. We would another question about PCOS. So I said before that at the beginning, a 30-year-old woman with regular cycles, never been trying, I would quote roughly a 20% chance of pregnancy any one cycle. Guess what? If I give you the letrozole and you have regular cycles, roughly a 20% chance any one cycle. Because assuming that it's the only thing going on, we fix the only thing going on and you have a chance. But typically, if you've not gotten pregnant after 3 cycles where you've released your egg, what we call ovulatory, with treatment with PCOS, we would then move on and certainly do a an evaluation. The question is, how much does embryo grading impact the results of an embryo transfer? This is a great question. We look at the embryos and we look at things like the number of cells. We look at the things like whether the cells are regular. But having said that, I am a big fan of the phrase, you can't judge a book by its cover. And although we do look and we do judge, it's pretty clear that sometimes you have the most amazing looking embryo, you don't get pregnant, and you have an embryo like, oh, should we really even transfer? It's all we have. And they have a beautiful, healthy baby. We are able to test embryos by testing the chromosomes with a really amazing technology called pre-implantation genetic testing. And we can test for a variety of things, but we can test all of the chromosomes. I kind of think of it like an amniocentesis for the actual embryo. Using it in younger women, more controversial, but in someone who's 38 or so, it can be a great way to supplement and even replace the looking at the embryo, the grading. Question about success rates for IUI and IVF. IUI is intrauterine insemination, and typically we'd use that with fertility drugs. And I only half jokingly tell women the good news, bad news with the clomiphene or letrozole and the IUIs will double your pregnancy rate. But if you remember earlier, I said the pregnancy rates might be 3% higher, 2, maybe 5. So we quote typically a 10% chance. IVF is wholly dependent on the age of the woman. The age is everything, but it's going to typically at least triple in a younger woman that chance of getting pregnant. But more expensive, more visits to the office, and when it's needed, we absolutely jump to it. We're so fortunate to have that technology, but it is not what, but the clomiphene is a good first choice. And there's a question about using a frozen embryo transfer, a medicated or natural cycle transfer. And again, that's a specific protocol question. And that would be what you would want to speak to your doctor about, because they're going to know your history and know the nuances and know what your endometrium looked like on the previous cycles. And then there's a great global question about how to improve chances. And it says implantation after frozen embryo transfer. There's so much on this. And the bottom line is there's nothing that's agreed upon. For stimulation to get more eggs, there's CoQ10, DHEA, and all these other issues, but none of them are standard of care. I very much acknowledge that it's not standard of care. I talk about vitamin D and baby aspirin, but they are very much not standard of care and very much not approved. And then for the lining of the uterus, there's different protocols to try to get that optimal. The one thing that is standard of care that I just want to make sure that everyone is on is a folic acid supplement. And I actually did research looking at it and such, and it's really so proven that taking a folic acid decreases the risks of really bad birth defects. And so that's such an easy thing to do. It doesn't have to be a prenatal vitamin. It just can be any vitamin. My partner doesn't have vas deferens. That's the tubes within the male testicle and scrotum that deliver the sperm. And so that's congenital absence. And they should see a urologist specializing in male infertility first. They'll look for something called the Yas gene and make sure that there's nothing else going on. But then and then what we would do is they would get the sperm from there if everything is okay. And that is a great way to get pregnant with IVF. A wonderful question. What should you expect during your initial consultation? I can only address what I do. And so the first thing is I talk about myself and the system and how things work. I then go over the history to make sure that I understand everything correctly. I understand the goals of the visit. And then I go through the evaluation. I go through the evaluation step by step to make sure we understand what we're doing. And I talk about what we would do for the different things that we find, meaning if we have a structural issue, we treat it surgically. If there's a male issue, follow up with the urologist. And then I say, we're going to skip ahead. And if everything's okay, this is likely what I would do. And in a younger woman, I would talk about fertility pills with inseminations. And we have a fabulous patient portal. And in that is a link that tells you all about it. And I ask you to read about it ahead of time. And I say it may be a little bit of a wasted time, but at that next visit, if we do go that way, rather than, oh my gosh, this is overwhelming, because it is so difficult to process and it's so stressful. you've had a chance to read about it, and I encourage everyone to come with written questions. And so that's what I do typically for the initial consultation where there's nothing that we know. There's a question about recurrent pregnancy loss, and that is where you've had more than one miscarriage. I just recently looked at the guidelines from England, Europe, and the United States, and they pretty much dovetail together. And we do a pretty thorough evaluation looking for the common causes of miscarriages. I very much don't look at the ones that are sort of, this is one place where you go online, a doctor says, oh, look at me, I'm doing this, your doctor doesn't care. We all want to give great care. We all want success. If something was shown to work, we would do it. But I go for the accepted ones. Again, I've looked at all the international guidelines, and then if we find something, we'll treat that. The good news about this terrible condition is that you tend to do so well. Even after 3 miscarriages, where just about everyone thinks they have no chance, the chance of a successful pregnancy without intervention is over 50%. And the chance of finding something on an evaluation is less than 50%. And if we find something, then we can target it and treat it. So what insurance covers IVF? The only thing I won't talk about is insurance. Our financial counselors are amazing and they can help guide you through it. There's different windows of time periods to sign up based on if you're working. Your human resources department is going to be a good resource for that, and they should be able to tell you. If you're uncomfortable talking about it with them, it should be confidential, and you're one of our patients, for sure, our financial counselors, who again are amazing, can go over the different insurances and at least provide you with the questions to ask. Because it used to be you had Blue Cross, you had United, and now there's so many policies within each company, it's tough to do it. There's a question about what is a high estrogen level compared to FSH. So that goes back to the biologic clock, the tests that we used for that. And it varies based on the lab or something, but similar, we said a high AMH and a high antral follicle count, the ultrasound is good. A high FSH is concerning, and a high estrogen is concerning. We don't do a ratio, so it's not compared to FSH, but an estrogen above, certainly above 75 or 80 would be of some concern. So someone was asking about andrology as the next step. One of the things that I'm so privileged to do what I do, to be able to take care of patients when they're the most vulnerable for something that's so important, but also for a field that's so advancing so quickly from what I used to do. And I can tell you some of the things that we work on, but this specific question was about andrology, which is male and diagnostic steps. There's a lot going on. I have to recommend to everyone to be cautious, because I've been doing this for so long, and you read about a new test, you read about a new study, and oh my gosh, it's the holy grail, I have to be doing this. And you change, and then the next year, the next study comes out, which is more definitive, that says it doesn't work. And I've seen this so many times, and there's kind of a saying in medicine, you don't want to be the first, but you don't want to be the last. And the challenge is, when do you start doing something that's new? Because it typically costs. Our patients and our infrastructure have limited resources. We want to do everything to get you pregnant as safely and quickly and inexpensively as possible. And it's tricky, and we use our judgment. But I've seen so many things that, the embryo glue, so many things that were the next thing, and everyone's going to be doing it. And then in a few years, you like, do you remember that? Oh my gosh, I remember going to a meeting and reading about that. So it is tricky. A question about the process after an egg retrieval. So we take the eggs out. That is, my favorite definition of a minor surgical procedure is one done on someone else, but it's a minor procedure. Anything meaningful happening that's serious, at most 1%. I don't remember the last time there was any complication. We do a lot. And then the eggs are then combined with sperm, and we see fertilization, and then we see what it goes to the next step, which is cleavage stage and then blastocyst stage. It's just terms. The most important thing I want you to take away from this question is there's a big normal step down or attrition. We typically don't get all the eggs that we see at the retrieval. The eggs that we get at retrieval don't all fertilize. The eggs that fertilize don't all divide, and the eggs that divide don't all make it to the stages where they're appropriate for transfer. An average egg yield, and this is like wildly varying depending on age, might be about 10 or 12. I definitely have gotten 60 at some young women, and I've definitely gotten on very rare occasion 1 or so. Fertilization, 60%, 80%, sometimes much more, sometimes much less. And then, so every step. So, but it's really going to vary for better or for worse. It's the age of the egg. So if we have someone who's 44, I would say their chance of pregnancy, maybe 2%, a very scary low number. If that 44-year-old uses a 25-year-old donor, their chance of pregnancy is maybe 50%. It's just amazing the impact of age on this. What part of the IVF process is typically the most taxing or difficult for patients? This is a great question. So I tell patients that the fear of the unknown for the shots is worse than the reality. It's so intimidating to do that first shot. The pain, am I going to do it properly? Am I going to ruin my cycle? After a shot or two, it's like you're not even thinking about it. I think the most stressful part is often after the retrieval, while waiting for everything, and then after the transfer, waiting for the pregnancy test, because there's less contact with our office, and you are personally doing less intervention. You're doing less things to help your cycle. So I think personally that's the most difficult. But having said that, it's a very individual process. And again, I'm recognizing and stressing the stress with all of this and letting you know that we have resources. Is the second round of IVF typically the same as first? My insurance doesn't cover infertility, so the answer is yes. Sometimes we might use more medication or less medication, but if you start everything over again, the costs would all be there. Hopefully we have frozen embryos from that first cycle. So sometimes we freeze all the embryos, and hopefully even if we transfer, we have additional ones, and that generally is less expensive. And the great news is the pregnancy rates are comparable between using that frozen embryo and a fresh embryo, as well as the fact that it's not as many medications and all that stuff. There's a question about hatched embryos. So an embryo, the outer cells of the embryo will eventually kind of give way, and the embryo extrudes. In my mind's eye, I just think of it as a chick breaking out of the shell. This is another thing that was like, oh my gosh, we have to do artificial hatching of all embryos. It's pretty much accepted that all things being equal, an embryo that's starting to hatch, starting that process, is probably more likely to implant, but very much not a rule. And we very much don't routinely do assisted hatching anymore. Assisted hatching is where we help the process. Another point that's important is when we look at embryos, it's a snapshot in time. And so, you look at an embryo and it's 8 cells. If you looked at it an hour earlier, it might have been 4 cells. And if you look at it an hour later, it's 16 cells. So when we look at embryos for the number of cells for hatching, it's really important to recognize it's just a snapshot in time. Does having a C-section make your next pregnancy high risk? And the answer is that typically no. We do know that women with repeated C-sections are more likely to have the problems with pregnancies in terms of the placenta, the afterbirth, may be adhering to that C-section. That's typically able to be checked for with ultrasounds, and the key is to find out about that. But women with multiple C-sections, those pregnancies are more risky. I talked earlier about a term, inter-pregnancy interval, and we want you to wait maybe 18 months between those pregnancies. And then that C-section also places you at a greater risk for what we call a cesarean section ectopic pregnancy, where instead of the tubes, it's there. I treat these, I've written papers on this stuff, but having a C-section or even 2 C-sections is absolutely not a reason to try to get pregnant again. I'll say that again. It's not a reason to try to not get pregnant again. Timeline for switching from intrauterine insemination to IVF, 5th cycle of IUI, all things being equal, I would, at that point, go to IVF. Now, again, your individual history is important, but the literature suggests that oral medication with IUI, after 3 cycles, if you're not pregnant, it's reasonable to go to IVF. Now, if you're using just inseminations, just fertility meds without that combination, and depending on your diagnosis, it may not be the right answer, but absolutely you should be making an appointment to speak to your fertility specialist. 30 years old, everything is normal. How many cycles do you recommend before stopping? You're not saying what cycles, but how long before? So if you're trying on your own, we would give you a year. If you're trying with fertility pills, Clomid or Letrozole with artificial insemination, I would typically give 3 cycles, all things being equal. And if you're trying IVF, that's really going to depend on your response, on the number of your embryos, whether we want to consider, which typically not so much in younger women, testing the embryos, the average number of cycles needed. Statistics are important. We say that statistics hide as much as they cover. So if I said you had a 50% chance of pregnancy, which rarely I would, but sometimes, you think 2 cycles, you're pregnant. So I have 100 couples, 100 go through, 50 are pregnant, 50 are left. They go through, 25 are pregnant, 25 are left. They go through, 13 are pregnant, 12 are left. They go through, 6 are pregnant, 6 are left. They go through, 3 are pregnant, 3 are left. I can promise you, those 3 couples are so mad at me because I told them they had a 50% chance of pregnancy. And I don't blame them. I would have expected to be pregnant as well. So really, this is a question that statistics can tell you and also hide information, but really seeing how your response is. Have you seen patients with IVF success if they have Asherman syndrome, which is the scar tissue in the uterus? Just saw a patient today with that. It's something that it's within my area of expertise. The answer is absolutely yes. But having said that, Asherman's is one of the most difficult conditions to treat. This is scar tissue in the uterus, and it tends to recur, and it tends to put a pregnancy at higher risk. But having said that, it's absolutely not a reason not to treat it, and it's absolutely not a reason not to try to get pregnant. There's a clinical question about the cryopreserved embryos, not a clinical question in mass, and they're moving to another state. So there's several things. So a global question. I have eggs, I have embryos, I have sperm. It's either here or in another state, and I'm moving, or I want to transfer my care. And the short answer is that you can move all of those things. So you can either move them to here or move them from here to there. Some couples say, well, I'm moving, but I'm going to come back and do my cycle. So I'm moving, I've got friends here, whatever, I'll stay with them. I've got family, I'll do my IVF cycle, and I'll zoom in and do the transfer. Many programs, many sites, as a courtesy, will monitor patients for other clinics. So I have a patient that's moving to Denver. She wants to have her transfer here. My colleagues in Denver will do all the monitoring. You fly back just for that. My colleagues in Denver have a patient that's traveling through here. They're going to be here for a week. We'll monitor for them. That's not an issue. What is the process for lesbian couples? So one of my biggest privileges is to provide care for all patients. And in Rhode Island, we're one of the first states that recognized same-sex marriages that are married, but now we also will provide care for most, depending on insurance, for couples, even if they're not married. So basically, we go through an evaluation for core things, regardless of whether you've ever tried to get pregnant. For example, I test you routinely for chickenpox and rubella. Even if you've been vaccinated, your immunity may wane, and I want to make sure that you are immune before going to pregnancy. And then we can talk about history. We could talk about additional things. Do you want to test your tubes? Do you want to test for different things? And then typically we would use donor sperm. Rarely someone will bring their own sperm from a friend or something like that. That's logistically very challenging because of FDA rules. And then we have a number of sperm banks that we work with. And then we would typically just do inseminations without fertility meds, depending on your history. Sometimes we would add that. And sometimes we would even go to in vitro fertilization. One of the evolving things to know about donor sperm is historically the vast majority was anonymous. And the reality is that the anonymity is just a thing of the, that we just don't know with 23andMe and things like that. So, but I have a large number of single women, a large number of same-sex couples that we provide care for. I think that we, Boston IVF, give fabulous care, very importantly, respecting everyone's individual beliefs and giving the very best quality care. Another question about IVF success rates with very low biologic clock, and that's an individualized answer, and we could do additional testing to give you a sense. Will any mass insurance plans not cover going straight to IVF for a 38-year-old woman? I don't answer insurance questions. If I don't do it really well, I don't do it. But our financial counselors can help you with that. Aside from potential costs, what's the downside of not doing pre-implantation genetic testing? I'm going to say in younger women. And pre-implantation genetic testing is really accurate, and it will likely get you pregnant more quickly by selecting the embryo that's going to be more likely to take. And we know that the most common cause of miscarriage is chromosomal abnormalities. And if we screen those out, it makes sense. Any one embryo is more likely to take, and any one embryo is less likely to miscarry. And that itself is very powerful. So not only do I get pregnant potentially more quickly because I can pick the best embryo, but I'm less likely to undergo that heartbreak of a miscarriage. Having said that, there's the literature is a little bit not super clear. In younger women, it may not benefit as well. And it may also, when we started doing testing, I used to tell everyone that we may lose the embryo from the biopsy part. I don't remember the last time an embryo disintegrated as you took out the cells, but there may be a little bit of a hit to the embryo that it still can do, but maybe not quite the implantation potential. And it's thousands of dollars to do it. So certainly, if a couple has had a bunch of losses, if there's other reasons we do that, and then that's a discussion. If someone said they really wanted to, I'd be okay with that. If someone said, oh, it's a lot of money, but if you really think it's going to help me, doctor, I'm 30, I'm 35. If you think it's going to really make the difference, we'll find the money. Then I would say, no, I treat you like I would if you were my family. And if I'll say a very young sister, our daughter, came to me and said, should I do it? I'm 30, 35. I would say no. There's a question about the embryos not making it to day 6 and to the blastocyst stage, and that what should we do about that? That's a great question, but it's complex, and I would ask that you speak to your doctor about that. I recognize you're already doing that, so I'm not just saying, but there's too much in the history for me able to answer it. 37 years old, starting this process single. So I just want to say I applaud you for your courage. It's such a difficult step to take. And one of the first things that you're going to want to do is decide whether you want to go through inseminations to get pregnant now or freeze your eggs. And 37 seems to be a good number, a good age where we say it really makes sense to freeze your eggs if you want to wait. Because before you're 37, the data suggests that most women don't use those eggs and stuff like that. But if you're saying, I'm really just not sure what I want to do, I would speak about freezing the eggs. On the other hand, if you said, I am ready to start a family, I'm ready to take that step, doing it by myself, then we're there to help you. I'm there to help you. And we would talk about the evaluation, and we would talk about getting the donor sperm, and we would talk about going through all of that. How does PGT-A, that's the genetic testing of the embryos, affect the miscarriage rate? And the answer is that theoretically PGT decreases the miscarriage rate because what you're doing is you're selecting out the embryos that are chromosomally abnormal. And that's my experience. Does it make it zero? Absolutely not. Earlier, I said that we think that we know that chromosomal issues are the majority of miscarriages, but that's far and away from they're the only cause. So the question is combining two medications, Avistitol and metformin for PCOS, again, an individual question whether or not you have diabetes. Both are very controversial. I used to give out metformin like water. I still do. It's not the panacea. It's not the holy grail, again, that we thought it was, you know, and nothing is without side effects. So, so that would be a question. My husband had surgery for an undescended testicle as a child. Everything is normal except no sperm. We need to do a procedure, which is aspirating the sperm to see if it's there. So the undescended testicle, that may affect the sperm. Doing the procedure to try to draw sperm out, that if you do a number of them without question, can hurt sperm counts within the testicle. But having said that, there's really not another choice. So I would not, again, not knowing the history, I would say take the risk of it hurting sperm count because there's no other choice. And then you see what they get. And then the question is the pregnancy rate higher, success rate higher than 40% with IVF. Assuming we get sperm and assuming we get a bunch of embryos and you go through more than one cycle, yes. What is the age limit for considering IVF? That's going to be multifactorial, but we typically will not let a woman go through IVF above age 44. And even around that age, it's a fabulous practice. We actually meet all the doctors and we go through challenging cases. I've been doing this for 30 years. I'm not even the person who has the most experience. So you have centuries of experience as people run things by. And then if we say, hey, this woman is, my patient is older, I want to advocate for her. She knows that her chances are this. Are people comfortable? And then we have a discussion as a group. Do we feel it's ethical? You know, if all we wanted was money, which is not the case, we would let everyone through. But we want to be ethical. And although IVF is so safe, it's so safe, if you are the person that has that complication, and I felt that you had no chance of getting pregnant, then that's not me being a good doctor. So short answer, about age 44, depends on your history and such. How many eggs fertilize and how many implant? I love to say we'll put as many embryos back as you wish, but only one at a time. You know, back before our technology was good, I said I love what I do because we're always getting better. We would put back 2, 3, 4, 5 embryos. But now, as we're much better, in the majority of women, we put back just 1 embryo because we want to get you pregnant with a singleton. And couples say, oh, twins, perfect, we're done. Unless your babies are born at 28 weeks out of 40 and in the intensive care nursery and lifelong problems. So sometimes we will put back more than 1 embryo, but the thought is to put back just the 1. And then the great news is we can attempt to freeze the additional embryos. So it's not like we discard them, we would freeze them. And then if you're not pregnant, or I joke, if you're pregnant and want more punishment, then we can put those back later. And it's not until you exhaust all those frozen embryos that we would say we need to do a fresh cycle. If your insurance covers ICSI, is there any reason not to do it? And so ICSI is intracytoplasmic sperm injection, and that's where you put a single sperm into the egg. And it's used at about half of all cycles in the United States. And a lot of what we do, I joke, it's voodoo. I use baby aspirin, that's voodoo. This is data. This is the best level evidence where they take couples that don't have an indication for ICSI, and in half they do the ICSI, putting the sperm into the egg, and in half they don't. And pregnancy rates are no better. And so the answer is, for me, in my practice, all things being equal, I would not recommend ICSI if there's not an indication. But if there is, oh my gosh, it's a fabulous technology. Is an antral follicle count of 9 good enough? So we get multiple, for IVF, we get multiple tests for biologic clock. And so it all depends, like, you know, if you have 1 good test and 3 not so good, or, you know, it all varies, but just that number itself, knowing just that piece of information, absolutely. An antral follicle count of 9 is fine for IVF. Question about baby aspirin, and it's baby aspirin 81 milligrams. I was told to avoid it. If they tell you to avoid it because they have your history. And I love that question because you're asking a general question, but your team knew the specifics of your history and they said not to. Listen to them, not to me. How many IVF cycles would you allow before trying IVF with no insurance? So the data is pretty clear, great question, that the majority of pregnancies occur within the first 3 cycles of artificial insemination. That's not to say that after 3 cycles, if you have not been pregnant, you're not going to. And that's just a discussion. You know, if the inseminations are really inexpensive for you, maybe your insurance covers just that, and you're younger, I would say definitely we should keep going. And some couples say, we choose not to do IVF based on our religious, our ethical reasons, our financial coverage. Of course, I respect that. And we can keep doing it. And I would just counsel you that whatever pregnancy rate I quoted you, and I said earlier, like the fertility pills and IUI inseminations, about 10% a cycle, it's now going to be less. But there's no question that assuming there's not been a problem, you know, like if there's no sperm count, that's an issue, that you could still potentially get pregnant. Long-term health of IVF-born individuals, the scientific evidence, love that, evidence-based. And there's a lot of there. And here's the bottom line. I counsel that absolutely, positively, there are concerns, congenital anomalies, early deliveries, and other things. Fortunately, with just putting one embryo back, we avoid a lot of the big things. Having said that, one of the things I found interesting in my career is that different studies show different problems. So I want to emphasize, I counsel my patients that there is an acceptance that there may be some small increase. But the studies show different things. And my bias is if there really was a strong cause effect and it was meaningful, everyone would there would be a meaningful increase in the same thing. So I don't recall a patient ever saying, I'm not going to go through because of those risks. And also some studies, but not all, compare IVF babies to those that are naturally conceived in couples without infertility. And we know just infertility alone can increase the risk of issues. But having said that, IVF babies compared to spontaneously conceived infertile couples are still issues. So we know that, we're aware of that, but I would say there's nothing in medicine that's as closely watched as IVF. We're probably the only one that reports to the CDC and our own internal organization for our pregnancy rates and outcomes. So it's very highly tracked. And again, I treat you like my family member. And if you needed IVF and you were my family member, absolutely, I would do it. The follow-up question was the risks with the embryo biopsy. And I talked about that, the major risk being sort of the biopsy itself of the embryo, not an increased risk of defects, but whether that embryo is less likely to take. And then very importantly, nothing is perfect surprise. So with that biopsy, I always tell you that we can't be certain it's accurate. And we do recommend still genetic testing. I am 37, no issues, 4 inseminations. We'll using ICSI. So we talked about that. The ICSI, if you don't have an indication for it, will not. Importantly, though, every once in a while, a couple goes through IVF and they have no fertilization or poor fertilization. And they're like, why didn't we do ICSI? And the answer is because moving forward, we didn't know it. Now that we have that additional information, we would change to add it. But again, very good literature, very good science that says if you use it in people without risk factors, it does not help. So the interested in donor eggs for someone who's 44, great question. So there's risks of the chance of getting pregnant, the risk of a miscarriage, the risk of an anomaly, and the risk to the pregnancy. So let's say I am 40, my chance of getting pregnant with IVF, 10, 15%. I use a 30-year-old, their chance, 40%. My risk of a miscarriage with my own eggs, 40%. Risk of a miscarriage with a 30-year-old, 15%. My risk of Down syndrome, as one example, 1 in 100, at age 30, 1 in 1,000. So all those things are markedly better in a 30-year-old. The only thing that doesn't change is the pregnancy itself. We know that as a woman is older, higher risks of high blood pressure, diabetes, C-section, things of that. And so what we want is we want you to have a safe, healthy pregnancy. So routinely in women that are older, we would check to make sure that you, depending on your medical issues, we'd have you be cleared for that. The chance of multiple pregnancies, it used to be IVF gave the multiple pregnancies. Now, many women are having IVF, so we have multiples, but many of the multiples are from the fertility pill. That runs about 10%. And if you put back a single embryo with IVF, your risk of multiples is quite low, kind of like spontaneous twinning. Having said that, if you put back more, you have risks. So without question, there's risks of multiples with both IVF and fertility pills and fertility shots. Our job is to get you pregnant with a healthy singleton. Cost, there's a cost question. I'm going to defer that because, again, that's what our financial counselors. The Pixie dish is a special dish that's used to help fertilization. Again, it was a holy grail. We should be using Pixie for everything because it's going to improve fertilization, much less used now. Do you always put women on meds for IUI? Totally depends. Yeah, I'm going to answer the question, but again, it depends on your history. So if I have 400 couples, they are no known reason for not getting pregnant, meaning like we've done the evaluation, everyone's healthy, regular cycles, regular sperm count. 100 couples try on their own, 100 couples do just the artificial insemination, 100 couples do just the fertility pills with timed intercourse, and 100 couples do the fertility pills and the timed and the inseminations. The first three groups are going to be all roughly the same. And my governing body, my trade organization, says it's really only when you add the two together that you get the bump in pregnancy rates. But again, that's going to be depending on personal history. And I would not say for you that that's the bottom line answer. You need to talk to your doc. But I, in my practice, would typically put people on medication, all things being equal, for unexplained infertility. Success rate for natural pregnancy after IVF, without question, one of the greatest joys is someone that says, hey, I had to go to you for my first baby, but now I got pregnant on my own. And I'm like, awesome. Why? Don't know. I told you that even in that 3 years of infertility, you've got a 2% chance of getting pregnant. And that 2% could happen after you go through and get pregnant with us. Or maybe as we enlarge the ovaries through the fertility medication, we move the ovary closer to the tube, the anatomy has been shifted, or maybe the medications we give you with the pregnancy are altering your hormones, and maybe we're making these subtle changes. I have a number of patients who take so long to get pregnant with their first baby, and then the second baby, boom. I saw today someone who got their first pregnancy, was done literally like the first month they've tried, and now they've been trying for years. It's so frustrating. So there's a lot we don't know, but without question, some babies happen really quickly. Are there other practices in Boston that do IVF? Absolutely. You go online, you'll find them. If you want twins, can you transfer 2 embryos? Absolutely. Go to one of my competitors. Let them do it, because I won't transfer 2 embryos electively because it's the risks. I'll transfer as many embryos as you want, one at a time. Now, there are absolutely circumstances transferring 2, but if it's appropriate for one, you're gonna have a tough time getting me to transfer 2. A question on autism, behavioral disorders, that is not my area. The question is specifically Tylenol. I have not seen that. It's not my area of expertise, but I would offer to you that I say if I do things great, I do it. If I'm not really good at it, I'm just not going to do it because there are other people that can provide the answer. How do you make sure the right embryo is transferred to the right person? That is such a great question. It is terrifying to everybody, but not to me anymore, because I've seen how careful we are. Where the embryos are so put with the right patient through every step. Through every step, we take the eggs out, we make sure the sperm, and when you go through our practice, you see how many times we identify you and the different ways we identify you at every step of the way. We're confirming your name, we're confirming your date of birth. If it's the team, we're confirming your medical record number. We do all these things, we want to identify you. And those same steps, just so carefully checking, are done at every step of the way with the eggs, with the sperm, and with the embryos. And then when we put the embryo back, we're doing all those same things. So we just do so much because it's such a big deal. Having said that, if you go online, without question, there's been issues. I'm not personally aware of ever an issue at Boston IVF, and we have, I don't know, 100,000 babies. I'm not sure, we have a lot. So it is a great question. So the question is about progesterone in oil for a frozen embryo transfer. And this is a great question. There's data on this. So in the first half of the cycle, you're making estrogen. In the second half of the cycle, you're making progesterone. And so if we do a frozen embryo cycle, there are different protocols, as I said earlier. We pick the protocol that we think is best for you. And that protocol may or may not have you making an egg on your own. If you make an egg on your own, what we call a natural cycle, a semi-natural cycle, then you're going to be releasing that egg and you're going to be making some progesterone. And in that case, we are supplementing your progesterone on top of what you're making. But on the other hand, if we choose based on your history to give you the best chance of a safe, healthy pregnancy, where we don't have you make an egg on your own, where we just are giving you hormones, then you're not making any progesterone on your own. And therefore, we're not supplementing, we're replacing. And there's good literature to say that if we use just the vaginal forms of progesterone, the pregnancy rates are less. So we have two choices. We can use the intramuscular pregnancy alone, intramuscular progesterone alone, 1 shot a day typically, or you can take the vaginal and intramuscular, but only every 3 days. Intramuscular is no fun. It's not like the subcutaneous shots we use. And intramuscular may be very expensive based on your insurance. Some people prefer it. Some women prefer it. I just hate placing that progesterone in my vagina. I have no problems taking the shot. I'd rather do that, and that's always okay. But so it depends on your type of transfer protocol, and then it depends on whether you want to take intramuscular or not. So depending on the type of it, I absolutely recommend that you take the intramuscular to give you the best pregnancy rate. Someone wants to talk about family balancing, and so that is a great option. It's one of those really ethical questions that we ask. Should we be playing God? We absolutely don't screen for color, hair color, or intelligence. And years ago, we didn't do this, but when I think about it, in the countries in certain parts of the world where they would drown the baby girls, and in my practice, for every couple that wants a boy, another couple wants a girl. It's called family balancing, and we do that. But for that, you have to do IVF, and you have to and we have to test the embryos. Fibroids, how do fibroids affect fertility? That's a great question, and it depends on the location of the fibroid. Fibroids that are in their cavity, there's science. You go to 10 people that do what I do, at least 9 of us would say those need to be removed. Fibroids that are outside the cavity, outside the uterus, most of us would say if they don't bother you, they don't bother us. It's the ones in the wall of the uterus that is tricky. The ones in the wall of the uterus are depending on how big they are, whether they're pushing in the uterus and such like that. There's a question about doing an endometrial receptivity assay. There are a number of biopsy tests that we do with IVF, whether it's checking for endometriosis, whether it's checking for whether the lining of the uterus is at the right stage, the window of implantation, whether it's trying to help the embryo put in. They're all controversial, lots of data, and I don't routinely recommend any of them. I'll say that again. I personally don't routinely recommend any of them. There just was some data that came out that was one of oh, this is going to be great. We're all going to be doing it. And it said, no, it doesn't really help. And maybe even it may even be worse than not helping. And they all cost, and the biopsy is not comfortable. Having said that, it is something that we definitely talk about, and there are definitely cases where we would consider doing it. So again, we individualize patient care. I'm giving global answers for global questions, but again, we're going to individualize patient care. I see we're at 8 o'clock. I have to say these are fabulous questions. I've done a number of these, and these were great questions. I think you have access to how to see me or one of my terrific colleagues. Someone asked, are there other programs in Boston? Absolutely. Are they as good? I'll let you decide. But it's just wonderful. And most importantly, I just want to say that I recognize the struggles of what you're going through, how difficult it is. And I'm really so proud to be part of a team that really understands that and wants to make things as smooth as possible. And again, that goal of giving you that healthy pregnancy. So I wish you the absolute best of luck. Take care, and I thank you for joining us today.